Welcome to today's Healthier Washington webinar. The topic for today is using shared decision-making and patient decision aids to engage patients and drive quality. Our presenters for today are Dr. Emily Transue, who's the Associate Medical Director for the Washington Healthcare Authority, and myself, Laura Pennington, the Practice Transformation Manager for the Healthier Washington Initiative here at the Healthcare Authority. So before we get started, I'd like to briefly walk through our objectives for today's presentation. So Emily's going to walk us through first an overview of what shared decision-making is, as well as the difference between shared decision-making, the practice of it, and patient decision aids. And then she's going to explain why Washington State is certifying patient decision aids. And then I'll take us through how shared decision-making supports the goals and vision of Healthier Washington, tell you about our progress to date, and our vision for the future. And we'll take questions at the end, but in the meantime, feel free to type any questions in the chat box, and we'll capture all of your questions, and then leave plenty of time at the end to address those. So I'm going to turn it over to Emily now.
Thanks so much, Laura. So we'll start by doing an overview of shared decision-making and patient decision aids. So what is shared decision-making? Shared decision-making, I don't usually read slides, but I'm going to read this one, is a process in which clinicians and patients work together to make decisions and select tests, treatments, and care plans based on clinical evidence that balances risks and expected outcomes with patient preferences and values. I feel like we could probably spend about 10 minutes on this slide. There's sort of a lot of pieces of this that I think are really critical to understanding this process. So this really is about clinicians and patients working together. It's around decisions. So this is how you approach something where you have a reasonable option in one direction or another. And that can be in regards to tests, to treatments, to overall care plans. This should always be about using the clinical evidence to understand the different risks and benefits of the outcomes. But it's really also about patient preferences and values. So this is a little different from things like informed consent, which is kind of the making sure someone knows what they're getting into. It's a little deeper in that it assumes that there's a couple different options somebody could take, and you really want to understand why that particular person would make that particular choice. Just to wake everybody up a little bit, I'll give a personal example of this. I fell off a trapeze a few years ago, that's another story, and landed with a really severe wrist fracture. My wrist was kind of pointing off in a very unfortunate direction. And in the ER, I was seen by a surgeon who spoke about 6 words to me. He's now retired, so I think I can talk about him safely. And he said, "We'll fix that." And I said, "Good." And he said, "Sign here," and gave me a piece of paper, and I said, "Aren't we supposed to have a conversation?" And he looked at me and he said, "You'll be fine." So I signed, and I was fine. That was really a failure of informed consent. I should have known what the risks were, what might happen before we went into surgery. It wasn't so much an opportunity for shared decision-making, though, because this wasn't something where there was any chance that I was not going to have my wrist put back in the right direction. So this is really about cases where there's an exploration of the patient's preferences and their values that you want to get to by going through this process. A lot of this is about trying to get patients more engaged. So what does it mean for a patient to be engaged? And think about this in regards to your own care. If the healthcare provider suggests a procedure or a test, are you going to ask them questions about that? When you're faced with a decision, say, should you take this medication for your cholesterol or shouldn't you, do you explore that with your doc in terms of the different pros and cons of doing that? And if someone recommends something to you, are you the person who signs the consent form, or are you the person who asks for some additional information? And maybe, of course, you might be in between, as I was when I was lying on the gurney that day. Where do patient decision aids fit into this? So a patient decision aid is a tool that providers can can use in sharing decision-making to really get the patient engaged about their decision by providing them with additional information. There are a lot of different forms that these can take. They can be short or long, complicated, pretty simple. Sometimes it's a written document. It could be an interactive website that takes you through a lot of different options. A lot of them have video components, or it can be a visual aid. So looking at the one on the right side here, this is a little small, but looking at that picture, you can see, okay, the 100 people don't take a statin, the green ones don't have a heart attack, the red ones do. The lower cases, if you do take a statin, this green ones still don't. There's a group of yellow ones who kind of change from one category to the other, and the red ones still have the heart attack. So this is the way that somebody can kind of look at something and envision themselves sort of fitting into one of those categories, sometimes much more clearly than just handing them a statistic would do. So the goal of a decision aid is to make these options meaningful for them. And I do want to call out, these are not a substitute for the conversation with the doc. These are really to support that sharing. So the goal here isn't that you would hand this product to a patient and they would come back and say, yeah, I want to have a hip replacement. The goal is that this aid would really help them to have that shared conversation with their provider, and together they'd be able to explore and get to a good decision. The provider. So Matt Handley tells a great story about doing a presentation around this and sort of starting the day saying how many docs in the room do shared decision making. And of course, we all raise our hands. Of course, we all do good shared decision making already. I'm not that doc in the ER. I say more than 5 words to my people. We share our decisions. But once you really explore what it means to do that shared decision making, that exploration of values, if you ask at the end of the day, how many of you were doing this already, you don't see any hands go up. So this is something that really is an educational opportunity for providers as well as a tool for patients. Evidence around the use of decision aids. There's a lot of this. There's some newer citations in addition to this one. There's a lot of clear evidence around the benefits of decision aids. They do improve patients' knowledge of options in both the directions under consideration. They lead to much more accurate expectations of both the benefits and the harms of those options. And they lead patients to make choices that are more consistent with their values. So for example, surgery can involve sometimes a more definitive outcome, but going through some higher risks beforehand in some cases and a tough recovery. Patients who have used a decision aid are more likely to make the choice that fits with what they care about most. And they promote greater participation in decision making. So when a decision aid is used, the likelihood of that really robust conversation between the provider and the patient is much higher. There are a couple of other benefits that have been well documented that I think are important to talk about. One of those is around health disparities, which I know are a big interest to us here at HCA and to a lot of you on the phone. There's good evidence that populations that tend to underutilize services, if they are exposed to a decision aid, are more likely to get those services, and populations that overutilize are more likely to come down. So there's a lot of discussion, well, are you less likely to get a hip replacement if you have used a decision aid? And the way that seems to be playing out is that, if you look at, for example, minority populations that often have many, many fewer surgical procedures electively than other populations, they have an increased risk of wanting to pursue that after these kinds of interventions. And for other populations that are sort of overusing at baseline, they come down. So I think that's another really valuable role in addressing disparities. So, why Washington? A couple different reasons. So a state law was passed around shared decision-making that does a number of interesting things. It's got a definition of shared decision-making and patient decision aids, and it creates a higher level of liability protection when shared decision-making is used. And I'll talk a little more to that in a second. It recognizes certified aids, so certified aid needs to be used to trigger this protection, and that can be either state certified or nationally certified. And the legislation enables the HCA's medical director to certify decision aids. And essentially that higher level of protection says, if there's a lawsuit in which the patient says that they weren't aware of what the risks were, it changes the burden of proof. So if the shared decision aid was used, then the patient basically has to prove that they weren't informed, whereas if it wasn't used, then the provider has to prove that they get informed. We've found this isn't really the thing that motivates docs to use these. That's much more about wanting a better quality of relationship and a better quality of decision for the patient. But it does sort of add something to the equation, and it creates some opportunities for example, liability insurance carriers to be kind of interested in helping to support this work, which we think is really exciting. Why does state certification matter? As there's more evidence that these are useful and they're being used more widely, having good standards for good aids is critical. As you can imagine, if there's bias within an aid that pushes toward a certain decision, that can be a real problem. These are really, really useful if they're good aids, but they're potentially have some dangers if they're not. So it's important to have standards applied. The state, as a purchaser, you're probably all aware that between Medicaid and public employee benefits, we purchase healthcare for about a third of the non-Medicare population of the state. We're really able to play an important role in promoting use of high-quality decision aids and shared decision-making. As we mentioned, the liability protections are activated by the certification in the state. And we really have the opportunity as Washington State to serve as a national model in this work. We get a lot of calls and a lot of outreach from other places that are interested in and excited about this work and want to follow what we're doing. Certification criteria and process, and Laura will speak to this a little bit later. We have a pretty well-defined process around this, which we developed in collaboration with local national experts. We've had grant funding from the Gordon and Betty Moore Foundation to really put this program together and support development of the process. And it's based on standards that were established by the International Patient Decision Aid Standards Collaboration. Really glad I got through that, okay? Also called IPDAS. So this is a group of national experts and international experts that have gotten together to say what should be in an aid. And have created criteria. They don't actually do the certification, so we've kind of taken that on. Additionally, the National Quality Foundation was expected to start certifying aids, but also hasn't moved forward with that. So for the moment, we're actually pretty much the only ones out there who are actually doing certification. What are the criteria? They're really aiming to assure that the aids are accurate, unbiased, up-to-date, understandable, and do that key work of clarifying values and preferences. So the criteria have to do with things like, is there a balanced amount of presentation of all of the different options? Do they look at pros and cons? Are the numbers presented accurately and understandably? Is there data to support what the aid is putting forward? Again, they're based on the IPDAS standards. And there has been some adjustment over time as we kind of gain experience with this process of really thinking about what the most critical features of a good aid are. There's a reference link here so you can see the full set of criteria. So now I'm going to hand it back to Laura to talk about how this work supports the goals of Healthier Washington.
Great, thanks, Emily. So before we talk about Healthier Washington, I want to briefly mention that shared decision-making was first mentioned in the Affordable Care Act. Section 32 or 3021, specifically promotes the incorporation and testing of innovative models that incorporate shared decision-making. And Section 3506 also talks about the certification of decision aids as well as directs HHS to award grants to develop, produce, and test PDAs, as well as the education of physicians about their use. Unfortunately, at this time, as great as these this language is and what its intent is there was no funding attached to it. So at that time, there wasn't widespread uptake or use of this, and our legislation that promoted the certification of decision aids as well as the spread of a pilot was prior to the Affordable Care Act. Again, great intention, but no funding attached. So through the SIM grant, we were able to put shared decision making in as one of our goals, which specifically supports Goal 3 around patient and family engagement, as well as Emily mentioned, we received the private funding from the Gordon Betty Moore Foundation around the same time that we also received the SIM grant to develop a certification process, which we were fortunate enough to be able to build on the expertise of many national experts as well as international that have gone before us to do this work. So what we're doing as far as promoting shared decision-making within Healthier Washington is we recognize that shared decision-making is a key component of patient-centered healthcare. So we felt that it was important to include it in our Healthier Washington activities, specifically under the goal area of patient and family engagement, which I mentioned before. So it is critical to good patient-centered care that patients and their families are engaged in the decisions that affect their health care, and they're empowered with information to make the best decision of care for them, which also takes into account their personal preferences and values. So within the Healthcare Authority, as well as Healthier Washington, we follow the best practice guidelines developed by the BREAT Collaborative. And the BREAT Collaborative does include best practice recommendations that include shared decision-making, as well as the use of certified patient decision aids. So specific activities that we're doing within the Healthier, within the Healthier Washington Payment Model 3, or the Washington State, otherwise known as the Washington State Accountable Care Program, within those contracts, and those focused on the public employee population, or PEP, there's language that mandates shared decision-making with the use of patient decision aids. Originally, it was our intent to have that language state with the use of certified patient decision aids, but we were still very early in our certification process that we just weren't sure how many certified aids we were going to get, so we changed that to just say the use of patient decision aids. So we're currently running pilots, shared decision-making pilots that focus on maternity care, specifically around VBAC at 3 testing sites, and are in the process of doing an evaluation of the implementation of the use of shared decision-making as a practice, as well as the use of certified and non-certified aids. So I said we're not requiring the use of the certified aids, but at the 3 sites, 1 site has chosen to use a certified aid, and 2 sites have chosen to use non-certified aids. So although there's a lot of aids out there, not everybody submitted their aids for certification. Obviously, it's not required. So we also pointed them to some other aids that we thought were very good, and that's what they chose to use for this process. So although this does focus on the PEB population, this also has the potential to impact the Medicaid population as well. So additionally, through this pilot, we have providers in what we call Shared Decision-Making 101, or it's a skills course, through the use of online training modules. The online skills course has received very positive feedback from those providers and other administrators within those accountable care network sites. And so we've decided to roll it out for widespread use within the near future, as well as into 2018. So it's our goal in 2018 to train as many providers as we're able in what we call good shared decision-making before we universally promote the use of the certified aids. As the tools are not meant to stand alone, as Emily mentioned, we want to ensure that providers have a clear understanding of what good shared decision-making is and how the certified aids can enhance that experience rather than one without the other. Because you can have the best aid in the world and not do good shared decision-making, and it reduces the effectiveness, and vice versa. You could do the best shared decision-making in the world but not have a good tool. So they both kind of go hand in hand. So it's our intention, at least initially, to post the training or link to access the training on the Practice Transformation Hub web portal, and we'll send out an announcement when that is available. We're working closely with the Hub team to do that. And it isn't yet, but as it's specifically set up for the ACP providers right now, but we're working with both our vendor as well as getting some language posted on the Hub web portal for when that's ready. So we recognize through our transformation work that payment is the key driver in how healthcare is delivered. So in combination with our transformed payment strategies within Healthier Washington, we are providing guidance on how providers can change the way they deliver care under these new arrangements. I'm referring to our other payment models, Payment 1, Payment 2, and Payment 4, which I won't go into today. That's another webinar. So specifically within those models, as well as within the Accountable Care Program, we focused in on 3 key strategies to drive delivery system transformation. One is to implement the BRIE recommendations for various clinical procedures, certify patient decision aids and promote the use of shared decision-making to enhance the provider-patient relationships, empowering the patients to actively participate in their healthcare decisions. We use and promote the statewide common measure set to measure and define quality performance, as well as provide technical assistance through the Practice Transformation Support Hub to providers. So recognizing that providers face a multitude of challenges and many have experienced initiative fatigue, we're striving to provide that technical assistance to the provider community in the form of the Hub, which I just mentioned. The Health Innovation Leadership Network, we recently convened the Clinical Engagement Accelerator Committee, and we're looking at how to better utilize the membership of that committee to support the work of the providers and the ACHs, as well as within the Department of Health, they have the what they call the PCPI. It's the Transforming Clinical Practice Initiative for Pediatric Practices. That's another form of technical assistance. But specifically related to the Accountable Care Program, as it relates to shared decision-making, we really use the BRIE collaborative recommendations to drive our priority areas to inform shared decision-making. So let's take a look at a case study and how it applies to how shared decision-making and the use of the tool can occur between a provider and a patient. So Jennifer, she's a 30-year-old female member of the PEB program. She's pregnant with her 2nd child, and she previously delivered by a cesarean section for her 1st child. So she's interested in vaginal birth, but she's approached her provider who recommends a C-section due to various risks. So her provider is hesitant to approach the topic with her of having a VBAC, but she's really interested in this topic. So through the use of shared decision-making, the provider can give her access to either an online tool, a paper-based tool, maybe a video, to give her information that provides her knowledge about her risks versus the benefits that are specific to her particular situation, and then together they can come back and have a conversation to plan as best possible that she would either try to have a VBAC or go forward with a cesarean section. So that's a way that they can interact. Previously in our state, we had a high rate of unnecessary C-sections, and part of that was due to what we've been told is a provider's not unwillingness to consider VBACs, but maybe engage in that conversation with the patient. So the patient, this is one way where the patient can empower themselves with getting the information, asking the questions of their provider, going out, reviewing the tool, and then coming back and having that conversation with their provider. At the end of the day, it's not a foolproof method that she will be able to have a VBAC, but at least the conversation has occurred. She's aware of her risks and how it applies to her. And it also alerts her provider of what her personal preferences and values are around this topic. So what is a value proposition for a practice or provider to incorporate shared decision-making into their workflow? So as we mentioned before, shared decision-making is a key component of patient-centered care. And research shows us that engaged and activated patients have better experiences within the healthcare delivery system. So therefore, we can say patient experience is central to value, and it's also one of the key areas where we measure performance within our accountable care program contracts. Although there hasn't been specific research that's been able to tie shared decision-making to improved health outcomes, that is one of the things that we continue to track. So progress to date. So aligning with the statewide initiative, specifically recommendations from the BRE Collaborative and the Healthier Washington priority areas, for our first round of submissions, we reviewed and certified decision aids that addressed maternity health and requested aids that addressed only that topic. So in 2016, we reviewed 6 patient decision aids and certified 5. In 2017, we opened up submissions for patient decision aids that address total joint replacement, specifically around knee and hip, as well as spine care, spinal stenosis, particularly around lumbar fusion. And we just wrapped that up. The slice is currently reviewing, but we actually just made final decisions yesterday. And I'll explain how that review process went in a second. And also, just yesterday, we launched our third round of submissions, and those address end-of-life care. So we're very excited about this topic area as there's a lot of interest in it. So I don't want to give away how many were certified yesterday because we have not yet notified developers, but we will announce that really soon. So also going forward, keeping in mind that we follow the BRE recommendations. The identified topic area for 2018 is cardiac care, but don't quote me on that. That could be subject to change, but I think that's, as of right now, what we've identified. So our review process consists of 3 specific key steps. Our full review panel, the first major part of that is the full review panel. So this panel is made up of a core group of panelists that bring a variety of perspectives to the table, including the patient perspective, which is something that we're very sensitive to, having somebody at the table for that role. We try to get a patient perspective for that particular topic area. This time around it's been interesting, considering the end-of-life care, so we were able to get a caregiver to join us in this round. So the other perspectives at the table, we have clinical folks at the table. The first round we were able to get an expert in health equity. Unfortunately, that's been a little difficult to get between that round and this round. We've got some subject matter experts in end-of-life care this round. But the role of this full review panel is really to review and score the applications submitted by the developers along with the decision aids and any supporting documentation against our core certification criteria. This is a challenging role for these folks because it's really trying to understand what the intent of that certification criteria is and to identify whether or not the application and the decision aid adequately met or did not meet that criteria. So it's been an interesting process, and we've learned a lot along the way, and it's not an easy process. So the panelists who participate in this have just been fabulous, and we continue to grow and evolve our review process every time. And so a second piece of that is the panel of subject matter experts. These are experts who really are true subject matter experts in that topic area that understand what the current clinical guidelines and research are around that current topic. And so they don't review the full application against the criteria. They review the evidence that's been presented by the developers that they state were used to develop that decision aid. So we want them to tell us, does this evidence look like the current science that's out there? And if not, tell us what is, and that's the feedback we then give to the developer. So then all of those recommendations are then given to the chief medical officer at the healthcare authority, who under legislative guidelines has the authority to make the final determination. He then, again, also reviews the full application, the decision aid, the evidence as it's been presented, considering the input from all the panel members and the subject matter experts, and he makes the final determination to certify or not certify or to send back for corrections. So this is just kind of a visual framework for how the review process works. I won't go through it all the way. This is also on our website as part of a document called certification process. So it kind of takes you through, once we receive it, we do an initial review for completeness, or even to check to make sure it meets our initial criteria, eligibility criteria. And then it goes down to our full review panel for review, as well as our subject matter experts, and then to the medical director for review. We can also send it after that initial review back to the developer if there's any missing items. And then once the medical director takes a look at it and says, we would certify it if the following corrections were made. That's what we call opportunity to cure. We'll send it back to the developer and say, unfortunately, it doesn't meet this criteria. Here's some suggestions. If you're willing to make those changes and resubmit it, then we'll reconsider it. And last time that happened, and we did end up certifying a decision aid because of that. And then there's just some that it's just, sorry, this doesn't meet our criteria, and then it declines. And then so we follow up with the developers and let them know our final decision. And then the aids get posted to our website. So here's a list of the maternity ones that were certified. But I will tell you, so here's a link to that page. I will tell you, the links do not take you to all of the decision aids. The reason is that some of those decision aids don't cost. They're public access, and you can go straight to the decision aids. You can download them. You could access them online. But there's a couple of them that do have costs associated with them. So the links that we were given were by the developers that send you to the developer site. So we mentioned in round 3 that we're going to be accepting decision aids that address end of life care. So we had a long conversation about what's in scope and what's out of scope. So what's in scope are those decision aids that address potentially life-sustaining care, as well as palliative care or hospice care. And out of scope are aids that address general advanced care planning documentation, as well as any decision aids that address aid in dying. And I might ask Emily for any further clarification on these.
Yeah, we got a lot of questions about sort of what is general advanced care, what's included in that sort of general piece. And I think the best way to think about that is again, that these are about decisions. So there are a lot of great educational materials out there that aren't decision aids. So something like something that explained what a post form was, or what an advance directive is, or how you make sure that the legal documentation is done. Those are good educational materials, but they're not aids if they're not about a decision. Whereas if something was really, do I want dialysis or do I not want dialysis at end of life? Do I want to be on a breathing tube or not? Do I want CPR or not? Do I want to continue with life-sustaining care? Do I want to shift to hospice or palliative care? Those are the things that would be decision aids rather than the kind of general planning as such. So that's kind of the distinction that we drew there.
Great, thanks. So we think about this work that we're doing, so beyond the actual certification, this is really about translating the research from the IPDOS community into practice. And we talked about the BREE Collaborative, so I won't go over that, as well as the Accountable Care Program. But one other thing I wanted to mention, that Washington State has also included a requirement for shared decision-making with the use of patient decision aids, not certified necessarily, because we're still feeling like we need to get enough of a large inventory of decision aids before we start requiring the use of certified decision aids. But we included a requirement for shared decision-making with the use of patient decision aids into a total hip and knee joint replacement bundled payment contracts. Primera, they're the administrator of those contracts, and those contracts are with Virginia Mason. So, and we mentioned also the clinician training through the online skills course. So lastly, I just wanted to mention, we started out saying that this work that we're doing has its foundation in the legislation. So recently, because we've developed this certification process and this review process with the input of many people within our state and nationally, we were able to update the language in the WAC. And so the review and certification process has been defined and codified in the recent updates to RCW 7.70.060, which is the existing Washington law that addresses this. And so we put this out for public comment, and we did receive feedback from the public as well as our key stakeholders and partners, and we appreciated that and made those changes, and it's been finalized and is now in law, which we feel very fortunate. I only mention that because we feel very fortunate because, as Emily said, being the only state that has this policy to drive this work, it really, while there may not be dollars attached to it, it still really provides that foundation for doing this. And so our mission for the future is, again, to continue to spread the use of shared decision-making as a practice through training providers and the use of certified decision aids across Washington. We want to continue to work with the development community, and we have a lot of developers in our state. So we want to start encouraging submissions of different types of patient decision aids from developers, as well as we really want to start focusing on engaging patients in the decisions that impact their health care. So in 2018, it's our goal to bring together a variety of stakeholders to develop a plan or a roadmap of sorts to identify how to continue to move this work forward, and identify also what are our collective and respective roles. We think it's important to have policymakers, purchasers, payers, providers of healthcare, patients, and lastly, producers of patient decision aids at the table to collectively put our heads together to figure out how to take this next step forward to promote this across Washington. So if you're interested in participating in that discussion, beginning that discussion, I know we said 2018 convening, we'll be hosting a session at our upcoming Healthier Washington Symposium on Thursday, October 19th, and I believe registration information is located on our website. I'm getting some nods in the room. So that's it for me. didn't see that slide. So share your story. We'd love to hear from clinicians or clients who have used shared decision-making or patient decision aid. Contact us at healthierwashington@hca.wa.gov. So now we're going to take questions. We also have a link to our website on there, as well as our shared, there's a link to our shared decision-making webpage. So if you have any questions after the webinar, feel free to send them to our shared decision-making email box or directly to me. I'm sorry, Emily, you had something you wanted to add?
Oops, I was just gonna, we've gotten some questions, so we'll go ahead and start with those, but please feel free to send in more. As you can probably tell, this is all work that's definitely evolving, and we're very, very excited to have input. So please ask us questions. So a couple things we've gotten so far. Start with the simple ones. So question about whether the spinal stenosis decision aid and also the knee and hip are published and in the peer-reviewed literature. There is some literature out there. There's definitely literature out there about the use of decision aids in general, but most of the individual aids have not been specifically studied in the peer-reviewed literature. As you can imagine, it's a big expense to do studies on each aid. So these decision aids can reflect the literature that's out there on the procedures and on the outcomes, so they incorporate that literature, but typically most of the aids are not as such in the literature directly. What's being done to ensure that the decision aids that are approved are based not only on statistical evidence, but really incorporate patient preferences, which is a field that has a strong methodology behind it, as the questioner points out? This is a great question. Part of the criteria, a couple of the criteria that we use for certification are specifically around this question: how does the aid and does it adequately help the patient to clarify their values around the different options and outcomes? And the IPTAS, the International Standards Committee, has developed a couple of ways of thinking about this. Again, kind of based on some of that methodological evidence base around preferences. And it allows aids to do that in a couple of different ways. One is sort of asking patients to really directly think through which positive and negative features matter most to them. So a lot of them have Likert scales and other things to sort of let you think about, well, how would you feel about spending a longer time in the hospital but having a better pain outcome? How would you feel about having a blood clot versus not having had a surgery and not? So really working through a lot of kind of individual weighing of components of the outcome and how you feel about those to then help you bring together your values in relation to the whole decision. The other way that the criteria allow an aid to do that, and many of them incorporate both of these, is to really help the patients envision or image the physical, social, and psychological effects of each of these choices that they might make. So really incorporating, this is what it looks like if you do this and you have a good outcome. This is what it looks like if you do it and you don't have a good outcome. This is what it looks like if you try this one. So different ways that you can sort of help people to envision themselves in the situation. So there's a set of criteria around this topic of patient preference. That said, as we have our meetings with our panels and talk through the aids, this is definitely the one that the time goes into. It's relatively easy to say, yeah, this reflects the evidence, and yeah, the data was presented clearly or not. This is a humdinger in terms of really, does it get at those values deeply? So it's tough, but I think we do have some good ways to do it. As health economics, again, I'll read the question, as a health economics and outcomes researcher in orthopedics, what is being done to help surgeons see the need for their use in clinical practice and adopt that use? And this is, again, a really great question. We have, As HCA, we've started by getting some aids out there, and our next piece is really that education and broader dissemination. There are pockets where that's happening, and there's some good models out there for what it takes to really build something into people's practice. So there are, of course, sort of financial incentive options. There's building the requirement that it be done into contracts. But honestly, I think the most important thing is having clinical champions within an organization who really believe in this and can spread that understanding of the value of these practices amongst others in their organization. Have definitely seen that in the former Group Health, now Kaiser organization, which has really led a lot of the research around this and a lot of the work around this. Typically, it takes someone who has seen it in action, really believes in it, to then spread the sense of the importance. And then, of course, the next piece is to figure out how to build it into workflow in ways that are not disruptive for people and are easy to do. So it's a multi-step process. It's really important. It's happening sort of, I think, very, very well in a number of places in the state, and part of our challenge going forward will be to figure out how to spread that much more broadly. We are interested in any views that any of you have on how to do that. Great. Another great question. Are the total joint and spine fusion aids intended for use in a surgical setting or for use further upstream in primary care or in physical medicine, rehab, or physiatry? There's a lot of discussion around where these can best be used, and the answer is it's probably heterogeneous. So there's a role, I think, for early on, who should go to see a specialist, who shouldn't. Most of them currently are geared to be at the decision-making point, which is sort of, I think, usually at the early visit with the specialist. So if you've already decided, it's too late. These are not pre-op materials. But they are sort of points where you're having a serious discussion about whether you want to pursue it. So whether that is with primary care doc or whether it's with a specialist early on, there's a role potentially for both of those. But that's kind of the point where most of these are aimed.
So the next question is, from the state perspective, what are the key measures of success for the shared decision-making maternity pilot? We do have some measures. I don't have them off the top of my head, but generally, the intent of that pilot is to really embed shared decision-making into the workflow. So it's changing the culture of the practice. It's changing the practice of the providers, changing the culture of the providers, as well as the patients. So we're working with the University of Washington to evaluate this pilot. There's been, the evaluation is multifaceted. There's been surveys of the administrators, of the providers, as well as the patients. There's been some baseline surveys done, and then at the end of it, we're going to check again, resurvey, and through interviews to see, has there been a change in process, as well as that culture shift in the thinking of the providers to embrace this as a practice and see the importance of this, as well as we did talk a little bit about outcomes with the patient, but those outcomes are more related to the final decision that was made. And so the second part of that question is, what about for total joint and spine fusion? I will go on to say that the accountable care programs, they also have a requirement to work on joint and total joint, but we are requiring the use of decision aids on that, but we're not actually piloting that. so they're doing that work as well. When I think about what key measures or success are for the uptake of those, I really go back to uptake of the BRIE recommendations. I'm looking at Emily to see if she has any other thoughts.
Yeah, I would call out one thing that it's not, which is about whether people get these, which decisions people make. It's not a metric. We are not trying to encourage people to make any of these decisions in one way or the other way. What we're really looking for is that concordance of the choice they make with their values and the having of that real conversation. So these are tough metrics because they're kind of subtle. Yeah. These are not things you're going to pull out of claims. I think early on we want to see that people are using them, but this is a great question, partly because it's a hard one, because really it is about that quality of conversation. It's about that sort of satisfaction at the end that somebody got what they thought they wanted. Some of the studies have some really good ways of looking at that concordance, et cetera, but of course it's very individual survey based. It's a little harder to pull on a population basis. So more to come on that, but it is definitely not about did you get hip replacement, did you decide not to get a hip replacement.
Right. And I would like to add to, for my pitch about the Healthier Washington Symposium, we have invited members from our accountable care program sites who are working on the maternity pilots to attend to talk about their experience and lessons learned. So just wanted to toss that out there as well. Any other questions? So I would just like to say thank you very much for your interest in this. This is something we're very, I feel very fortunate in Washington State that we have the ability to do this, not only because of the legislation to support this work, but because of the resources within our SIM grant, as well as the funding we received from the Gordon Betty Moore Foundation, as well as the collective support from all of our stakeholders as we continue to push this work forward. So thank you all for joining us today, and please let us know if you have any additional questions. And the slides will be posted, as well as a recording of the webinar on our website.
I'll just echo those thoughts. This is work that a lot of foundational work has gone into this, and we really think that this is at a point where it's ready to start coming into its own and being spread much more widely, and we're very excited to have you all as partners in that. So thanks for attending today.